Oh, hi! So you clicked on this video because you want to learn something related to dentistry. Well, you are on the right place. I am Dr. Hina, the voice and soul behind drteeth, and this is the platform where we make learning interesting and incredibly easy for you. So do leave a like and subscribe to my channel, and I will recommend you to join channel membership to watch our premium videos. You can also visit our website for online classes, courses, MCQs. So let's get started. Hello everyone, Assalamu alaikum. Welcome back to my channel. Now this is one of the first videos I'm making after our app launch. I had been very busy for the entire month because our apps had launched. So many things have to be organized. So I could not make videos, sorry for that. But with this video, we are coming back on track. So today we are going to talk about the extraoral implant in maxillofacial prosthesis. Just a little story behind this presentation. This was one of the presentations that I had presented at a national conference in my post-graduation, and I had won the best paper award. So this is kind of special for me. Also, it was my journal club. So I have made a lot of, changes and modifications in this presentation. I have removed many images also, which I could not use because of copyright concerns. So anyway, let's begin. So we'll be talking about the historical perspective, various retentive aids, craniofacial bone site classification, implant designs and their correct placement, enhancing the prosthetic outcome, and extraoral implant in irradiated patients. Now, a successful prosthetic outcome depends upon many factors. Some of these are tissue evaluation, the extent and the location of defect, the structural design, the retention mechanism that we are using, whether the patient is undergoing radiation therapy or not. You must be knowing that in case the patient is undergoing radiation therapy, in those cases, implants are usually contraindicated. Then, patient compliance, if the patient is following your instructions to maintain the hygiene of his appliance. That also determines how successful our prosthesis will be. And now, with the advent of digital technology, a lot of these procedures have been simplified, have been made accurate, thus improving the success rate. Talking a little bit about the milestone, the only recorded case of maxillofacial reconstruction is between 200 AD to 1000, which is related to Byzantine emperor who got a golden nose manufactured. Then in the 17th century, Pierre Faucher designed an obturator, and in 19th century, a lot of advancements happened in the field of maxillofacial prosthesis, like vulcanite was introduced, and also the first bone-anchored device. Hearing aid Baha was introduced, bone-anchored auricular prosthesis, percutaneous craniofacial implant that we use till today were introduced in the 1984. Okay. Now, briefly talking about the retentive aids of the extraoral prosthesis. Now, the success of our maxillofacial prosthesis is majorly dependent on two factors. First is the retention, okay, and the second is the aesthetic, means the color. If any of these two is not right, if any of these two is not correct, then the prosthesis will be a failure. So, in retentive aids, we have adhesive, skin tape, spectacle frame, soft tissue or bony undercut, and obviously implant. Now, this is an article which was published in 1980. Here, the authors emphasized that a number of prostheses fail because of insufficient retention, and they proposed that anatomical undercuts can be created to improve the retention rather than relying just on adhesive. So they said that don't just rely on adhesives for retention. What you can do certain minor surgical alterations that can, improve the retention. Obviously, we have various disadvantages related to adhesive, like it can damage both the prosthesis surface and the skin during insertion and removal. They do not provide sufficient adhesion against gravity, or if you are sweating or there is tissue movement. And if adhesive systems are used for a long time, they may cause contact dermatitis. They may cause a change in the color of prosthesis. They can disrupt the prosthesis structure and abrade the edges. And for adhesive retained prostheses, we need thicker margins, and that makes them aesthetically unpleasant. So these are some of the major disadvantages of using adhesives. Now, if we look at the articles after 2000, the main focus shifted to osseointegrated prostheses. Now, this article was published in UCLA School of Dentistry, where Dr. Bumer et al. They compared various aspects of the prosthesis that can, enhance the quality of the patient life. So these were the perception of appearance, comfort, fit, irritation. So all of these factors were evaluated, and especially for reliability of retention, frequency of wear, ease of placement and removal, the results were statistically significant, and the patients preferred implant retained prosthesis over other kind of prosthesis. This is a very important classification, the craniofacial bone site classification, which was published in JOMI 1992. Here the bones are divided into alpha, beta and delta. So first we have the alpha bone, which is 6 mm or more. So it includes the maxilla and anterior mandible. So here we can retain the facial prosthesis, the obturators, zygomatic implants can be given here. And it is a obviously maximum load bearing site. Then we have the beta zone. Now here we have 4 to 5 mm bone. It is present in the superolateral, inferolateral, orbital rims, the mastoid margin of zygoma and the temporal bone. Then we have the delta bone, which has 3 mm or less bone. This includes the medial surface of the supraorbital rim, the pyriform edge, the infraorbital margin also, nasal bone, zygomatic arch. So these are the 3 kinds of bone we are having. Now talking about the implant design. The implants can be broadly classified into solitary implants, means individual implants, or collective implants, means grouped implants, means they are in groups. So first we will talk about the solitary implant. Now this is a classical craniofacial implant design. These implants are short implants, 3 to 5 mm long. They also have a flange. As you can see, it has a flange of 5 mm with perforations. So these perforations are given because these perforations increase the surface area and thus increase the contact with the bone. Also, the flange is given because it would prevent it from being pushed into the deeper structures, like so. Also here, the screw design is a reverse buttress screw design, which will help in the push out and the pull out forces. Obviously, the patient needs to remove it and put it back. So the push out and the pull out forces can be easily taken care of by the reverse buttress screw. Then the second type of implant is the collective implant. As you can see, these implants are joined together. They are also known as epiplates. So they are used in the minimal bone areas, that is the delta sites, and you can customize it depending on the site where you have to use. Then we have the conventional implants. Now our technologies are so advanced that we don't need that, flange like we had in the classic craniofacial implant. Now we don't have chances of accidental perforations of implant because we have a good imaging technology, and also the attachments can be CAD/CAM milled. Now, certain principles of implant placement. In order to prevent any damage, the skin layers should be surgically thinned, and this operation should be done 10 mm away from the abutments. The implants should be 1 cm apart from each other for hygienic purposes, and the bars fixed between the abutments should follow natural facial contours and be designed to improve the necessary hygiene. Implants should be at least 7 mm away from the hairy scalp, and if this is not possible, skin grafting should be performed. Now, auricular defects are the second most common craniofacial malformation. Now, if we have a small auricular defect, it can be corrected surgically. But in case if we have a large surgical defect, it is very difficult to establish the intricate ear anatomy. Therefore, prosthetic options are better for extensive defects. Now, how can we achieve a better prosthetic outcome? Here, total auriculectomy, means entire removal of the ear, is better than partial auriculectomy. We have to retain the triggers, this area, as it's a fixed anatomic landmark and it is not easily displaced. We have to avoid hair-bearing flap. Why? Because placing attachment is difficult and also cleaning is difficult. Very important slide, location of implant. How do you locate the implant position? So this is the external auditory canal. This is the right ear. For the right ear, we usually go for 2 implants placed at 11 o'clock position and 9 o'clock position. For the left ear, we have 1 o'clock position and the 3 o'clock position. Now the distance between the canal and these implants is 18 to 20 mm. That corresponds to the anti-helix region of the ear. Now this is chosen because it is really easy to hide the bar and clip in this area. The distance between 2 adjacent implants is 15 mm. Now for the ear prosthesis, bar and clip attachment gives the best result because of increased stability and retention. The only drawback is that we need bulk of prosthesis to hide these attachments. For the ear prosthesis, that's not an issue because we already have enough of the material, since we have enough bulk of the material. How can we precisely locate the position of the implant? We have conventional method where we can make a wax pattern and get an acrylic stent made. Here, as you can see, the acrylic stent is attached to the upper maxilla of the patient. So since it is a fixed anatomic landmark, the maxillary teeth are fixed, right? So we can precisely locate the position of the implant. STL models are very useful for assessing the bone thickness and precisely locating the implant location. One more method is image guided surgical navigation. Now here also CT data is used to construct a STL model for evaluation and treatment planning. This virtual data can be imported to a navigation system that provides guidance for accurate implant placement. Coming to orbital defect. Now, in a multicentric study conducted in US, implant survival rate for auricular prosthesis was found to be the best, followed by the nasal and then the orbital prosthesis. If the radiation dose of the patient is less than 50 gray, or if the patient is undergoing hyperbaric oxygen therapy, the survival rates are still more. Now, briefly, we'll be talking about the 3 types of orbital defect. The first one is the evisceration. Now, in evisceration, the contents of the eye are removed, but as you can see here in the image, the outer layer of the eyeball, that is the sclera, is left intact. Now, since sclera is not removed, the extraauricular muscles, it will remain attached. So, in this procedure, what we can do, we can place an implant inside the sclera in order to maintain the shape of the eyeball. So, outer appearance of the eyeball will therefore remain unchanged even though the patient might not have his eyesight. Then we have the enucleation. Here the entire eye including the globe is removed. As you can see here, we don't have that yellowish lining outside. So, the sclera is absent here. Entire eye including the globe is removed. Now, this procedure differs from evisceration. How? As I already told, because sclera is also removed here. So, none of the eyeball or the globe remains. Now, since we don't have sclera here, extraauricular muscles, it must be detached from the sclera. Now, in which cases we can do enucleation? Enucleations are done for infections or malignant cancers that are completely within the globe of the eye. Example, retinoblastoma or, in other cancers where the patient already has lost his vision, like melanoma. Also, enucleation is frequently done in trauma cases. Then the third one is exenteration. Now here, as you can see, the contents of the eye socket are removed, including the muscles, lacrimal gland, optic nerve. It's very invasive surgery. So this procedure needs to be done when we have large cancers of the eye. Also for aggressive infections like aggressive fungal infection. What challenges do we face in orbital defect? If the surgeon has closed the defect with a flap, we don't have space for the prosthesis. Do we have? No. If we have retained the eyelets, that also is a problem. So how can we enhance the prosthetic outcome? By minor surgical alterations. We have to line the orbit with the skin. Leave the eyebrows intact. Don't close the defect with flap. Do not retain eyelid. So if we have a defect similar to this, then we can have an enhanced prosthetic outcome. What is the site of implant placement? It is the supraorbital and the infraorbital rim. These areas are preferred because of thick cortical bone and good blood supply. What is the preferred retention system for the orbital prosthesis? It is magnetic. Why? Because of ease of insertion and removal. The only disadvantage of magnet is that it is corrosive in nature, but that's not a great problem for the extraoral environment. Coming to the nasal defect. Now, the patients of nasal defects are really less in maxillofacial field. Why? Because by surgery alone, most of the cases can be corrected and they are aesthetic also. They are providing function also. They are providing aesthetic also. But for the extensive defects, we may need to make a nasal prosthesis. And how can we enhance the prosthetic outcome? If the nasal bones are resected, if the floor of the nose has been lined with the skin, and the anterior portion of the septum has been removed. The site for implant placement for the nasal prosthesis, it is the floor of the nose and the glabella. The glabella has delta kind of bone, so it is not a preferred site and has many failure rates as reported in the literature. Now, we are still talking about the nasal prosthesis. If the patient is edentulous in the anterior area, so this is our nose, okay? And here we have our anterior teeth. Now, if the patient is edentulous, here if you don't have teeth, the bone thickness will be sufficient for the vertical placement of implant. 2 7 mm oral implant types may be used in this area. But in case if we have roots present here, the contact between the implant and the teeth should be prevented. So in those cases, we can use lateral wall of the pyriform aperture and we can place one implant on each side. Briefly, we'll talk about extraoral implants in the irradiated patient. So, irradiated patients are relatively contraindicated for implant placement. I had already told in the beginning of the video, right? Because of high chances of osteoradionecrosis. The cranial regions which are most affected by radiation therapy are zygoma, mandible and frontal regions, and the lowest failure rates were found in maxilla. Now, we give hyperbaric oxygen therapy in patients undergoing radiation, and it has shown to reduce the surgical complications and increase the healing capacity. According to literature, hyperbaric oxygen therapy can improve the implant success rate by 38%. In order to avoid risk, it is advised to wait for a period of 6 months to 1.5 years after radiation therapy. There are various schools of thoughts regarding whether to go for implant immediately after surgery and then wait for a few months before starting radiation, or not to place implant while resecting the tumor and let the patient have the radiation therapy and wait for a certain amount of time before implant placement. So with this, we come to the end of this video. I hope you found this video helpful. We can deal with all this in detail in near future, inshallah, with upcoming videos. The greatest gift we can give someone is the gift of life. Now, it is impossible to imagine the amount of psychological and emotional trauma patients of maxillofacial deformities undergo. But we as prosthodontists have the potential to help these patients regain their lost confidence, to regain the normal life back. So, it is a blessed profession and we should try our best to learn more, to, apply more and strive to get better in our skills so that we can make positive changes in people's life. Now, since you have made it to the end of the video, please subscribe to my channel and also hit a like. A comment will be really appreciated. I'll see you in the next video. Take care. Allah Hafiz.